Hi everyone, welcome to this live session on the MOOC resistance to antibacterial agents. So I'm Clémentine Schilt, I'm the head of digital education at Institut Pasteur. And I would like to thank Paul Rochette, who is the community manager of your MOOC, and the director who are online with us, so Philippe, Béatrice, and Didier. And so I will leave the floor to Paul.
Hi, nice to meet you, everyone. I'm Paul Rochette, so I'm a PhD student at Institut Pasteur in the synthetic biology lab, and I'm the community manager for this MOOC. So I'm glad to welcome you all for this live session. And yeah, I will let our MOOC directors to present themselves. So we have Béatrice, Philippe, and
So the woman first, nice to meet you too. I'm a medical doctor. I work in the hospital in the lab of bacteriology. And I work also on multi-drug resistance strain and on gonorrhea, especially, but it's not the topic of that today.
I'm Philippe Glaser. I'm working at the Institut Pasteur. I'm heading a research unit. The name of the unit is Ecology and Evolution of Antibiotic Resistance. And I mainly worked on E. coli and Klebsiella pneumoniae. And I'm also collaborating with hospitals and with also veterinary.
Hi everyone, I'm Didier Mazel. I'm heading a lab at the Pasteur Institute working mostly on the bacterial genome plasticity and with emphasis on the mechanism involved in the resistance gene acquisition and spread.
So thank you. We'll start with questions.
Yeah. And just before starting with the question, we would like to remind you the timeline of this MOOC. So the MOOC started in mid-January, and we are having the live session today, and in a few days, you will be able to pass the exam. So the exam is a paid exam that you can register for to get a certification. And after mid-March, the MOOC will still be available, but without any active answer to the forum, and then there will be a second exam at the beginning of 2026. Okay, so here just also, so we already had the presentation of the MOOC team, so we skip this, and we'll start with the first questions. So the first questions were on the mechanism and transmission of antimicrobial resistance. Here we go for the first question.
So the first question was how does antimicrobial resistance transfer from animal meat to humans, and what are the underlying mechanisms? So it's a tricky question because there are several levels of understanding of the question. So the first is that the antimicrobial resistant transfer from meat to humans is mediated by the bacteria that can be present on the meat, be they originally from other humans that have manipulated the meat, or from the breeding of animals. And so it's a classical transfer of contamination. You can get new strains by handling something that has been contaminated with bacteria. The second level is the transfer between bacteria, because even if you can have bacteria on animals that carry resistance genes but are harmless to human, and they even might not colonize the human body, but then you can have occasionally horizontal transfer of resistant genes carried on plasmids, or conjugative plasmids, or mobilizable plasmids, or transposon that can jump from a DNA molecule to another. And then the underlying mechanisms are the classical one, mostly conjugation of plasmids, or even possibly transformation. depending on the kind of species that you are interested in. But it's the same mechanism than for the rest of the transfer and spread among bacteria.
The second question is about bacteriostatic antibiotics, prevent bacterial multiplication. But what happens to the remaining pathogenic bacteria in the body? Could they still cause disease after treatment? So it's true that some antibiotics are killing the bacteria, like penicillin. Some are not. They are called bacteriostatics, like tetracycline. And in fact, now when we are developing novel antibiotics, we prefer to develop antibiotics that will kill the bacteria, but antibiotics that are bacteriostatic could be very good antibiotics. And in fact, what you should know is that the antibiotics alone is not so efficient. You need to have the antibiotics acting together with the immune system, and the immune system will eliminate the bacteria. That's why in most cases, even bacteriostatic antibiotics could be very efficient, and they will eliminate all the bacteria thanks to the help with the immune system. So in the case of immunosuppression, like for example for organ transplantation, antibiotics are not so efficient, even the ones that are killing the bacteria. Some bacteria are always somehow surviving, and it might be very complicated to really fully treat the infection.
Question 3 for me, what is the most promising novel technique for rapid antimicrobial susceptibility testing? So I work in the lab, so the best way now in 2025 is still to determine the phenotype of the strain. And to do that, we make an antibiogram. We need a bacterium that grow in culture on yellows. And you can see the colony or in medium, liquid medium. So in case of blood culture, you have the bacteria in liquid. The bacteria can be put on a gallery containing antibiotic, incubated for overnight, or on a gels, which contain antibiotics. They are deposited on it. So this is the classic way to determine the susceptibility of the strain. Now we have several solutions that are not now CIVD marketed, and we have recently buy some of them. So it's possible to shorten the period overnight and to gain 12 hours for determining the susceptibility of the strain. And actually, we have 3 manufacturers that have deposit technique that give result in 6 hours. But there are some limitations concerning this technique. So this technique must be possible in the lab. So it's not research. It depends on the type of bacteria. So now we have this kind of technique mostly for gram-negative bacilli. We have also a limited number of antibiotics tested because it's a beginning, and we need some guideline given by the Société Française of Microbiology of the UK European Society to give the result. So it's just complex now. So when we have the phenotype, it's better. But when we don't have the phenotype, we can give the genotype, and it can help when we find a resistant gene. Example, we found a CTXM enzyme, and we know that the bacteria is resistant to third-generation cephalosporin. And we can say to the clinician, don't use that because we found the gene and the phenotype of the strain. If we don't detect the gene, the clinician cannot be certain that the sensitivity of the strain is certain, because we have a lot of mechanisms of resistance, and we cannot rapidly obtain all the molecular determinants to say if the bacteria is susceptible or not. And in the future, we can if we have some possibility to test with whole genome sequencing bacteria, we can obtain the result of the molecular determinant of the strain. It's the future for me, and we need some interpretation in terms of sensibility and resistance when we found all the determinants in the strain.
Yeah. So the question 4, so what are the recent advancements in diagnosing antibacterial resistance, and particularly the person was interested in vancomycin resistant Staphylococcus aureus and carbapenem resistant gram-negative bacteria?
Okay, so I just answer for these two bacteria. From vancomycin resistant Staphylococcus aureus, to my knowledge, we don't have in the lab molecular tests to precise this point. For me, it's necessary to culture the strain to determine exact MIC in liquid media, because it's the guideline, and interpret the breakpoint. So we have some tests to detect methicillin-resistant strain, but not for vancomycin resistance. And for detecting methicillin resistance, we can use a molecular test or immunochromatography test on colony. For the carbapenem, it's better. So of course, we can have the result first of an antibiogram, and we found in the antibiogram that the diameter of carbapenem is reduced, and we have two possibilities of mechanism. So first, we have a production of enzymes that inactivate the carbapenem, or sometimes chromosomal modification can perform that, such as a loss of porine for Pseudomonas, for example, or an efflux pump that efflux the antibiotic. So, and in this case, we have a reduction of carbapenem activity. So it's not the same system to diagnose this resistance. So in the first time, we have some specific enzymes that produce carbapenemas, and these enzymes are on rapid test. They are IMP enzyme, OXA 48, KPC, and DMVIM. So for this enzyme, we have tests. We have phenotypic test and molecular test, and it's rapid. We have the result in 2 hours. But when there are not this enzyme, we can not perform the diagnosis. And in that case, you have some specific tests that call the CARBA NP test. And in that case, you have the result in 2 hours, but it's not so easy. Sometimes it's difficult to read the test. And at least we have some tests that comes now, but are not commercialized. We have not this test now, but we can expect that the mass spectrometry test can be performed to detect the hydrolysis of the antibiotic, but it's complicated now in routine in the laboratory. So for the future, perhaps.
Okay, thanks for your answer. And now we can move on to the questions that were about the policies to combat antimicrobial resistance. And the next question is, should the use of antibiotics be banned to prevent the emergence of antimicrobial resistance in livestock?
Yes, I will respond to this question. So first, there are 2 uses of antibiotics in livestock. One is to treat infection or to prevent infections as a medicine. But there was also the use, and there is still also the use of antibiotics as growth promoters. Indeed, if you provide a small amount of antibiotic in feed, then the animal will get faster than without. And so this was done in many countries, but now this is banned in some countries, like in Europe. And indeed, there was one antibiotic that was used. This is ovaparcin, that was from the same family as vancomycin. And the use of this antibiotic that is not used to treat patients, but as a growth promoter in animals, led to the emergence and to the dissemination of resistance to vancomycin in in Enterococcus, for example. So, and this is one reason why it was banned from the use of antibiotics as growth promoter in several countries, but not in some other, like, for example, in US, this is still allowed to give some antibiotics just to get the animal more fat faster. The other point is, of course, we are using also antibiotic to treat the livestock in case of infection or to prevent infection. And there are now some regulation. For example, in the EU, some antibiotics can't be used easily in the case of livestock, like third generation cephalosporin or some antibiotics that are of priority for human health. And in this case, you are allowed to use it only if the diagnostic has been done for antimicrobial resistance. Then the bacteria is resistant to other antibiotics. So this means that things are done to limit, in some countries, the use of antibiotics in livestock. And for example, in France, there is a 40% reduction of the use of antibiotics in animals compared to 10 years ago. But this is true only in some countries and not in others. So it's true that we should have regulation of the use of antibiotics in animals to avoid this contribution to the antibiotics crisis. Of course, the idea is not to ban it because it's important for animal health to be able to use antibiotics, but this should be limited to some molecules.
Thank you for your answer. So the next question is, what are the current challenges in antimicrobial resistance research in France?
The current challenge are mostly the funding and the lack of interest of the big pharma. So the low return on investment that the development of a new antibiotic can give to a company. So currently that's the main issue. There are several, well, it's not limited to France. I mean, it's an international position. There is currently the only way to overcome that is to find other source of funding, or there are several initiatives that allow to at least make the first screening and the first assay of the efficiency, but then when you start to enter the last phase of development, that costs a lot, and this is the main issue.
If I may add something, as you said, Didier, the challenges in developed countries are similar in France, in Germany, in UK, and even if possibly funding are probably higher in UK than what they are in France.
Okay, thanks for your answer.
Possibly one point is that I think that, for example, in UK, or this is really considered as a priority by the institution and by the ministerium, and probably it's less considered as a priority in France.
So a medical question, how can we effectively motivate the healthcare community to fight antimicrobial resistance? So a big question. So in my opinion, there are many areas in which we can take action. And the answer, it's not one answer, it's maybe different in the hospital, in medical, in outpatient clinic, and we may or may not depend on collective or individual action. It's not one answer. So they are also based on the knowledge of microbiological ecology, antibiotics, and recommendation of learned society. So first, in individual action, so it's at the level of the prescribing physician. The prescriptor choose whether or not prescribe an antibiotic. So, for example, he can choose to give an antibiotic or not if he thinks that we have an angina and this angina is viral. He can choose to don't give antibiotics, but it can be helped with practicing a rapid test to ensure that they are not group A streptococcus, for example. So if it's viral, no antibiotics, but if he can test, he can show that the bacteria is present and give antibiotics. So the first thing is to practice a rapid test. So second, the doctor may or may not choose to treat with a broad spectrum antibiotic. The broad spectrum antibiotic is an antibiotic that's active on most bacteria species, and their impact on the microbiota, of course. And you can choose to treat with a narrow spectrum antibiotic. So it's depend of the knowledge of the clinician. So we can help the physician to give him rapid access to rapid test, update the treatment guidelines, encourage to continue in education, and encourage him to networking. Now in collective action in the lab, the microbiologists has a role to play because he performs the antibiogram, and if the microbiologist don't perform an antibiogram, he can give to the clinician, don't treat. It's one option. And also the microbiology can report multi-drug resistant bacteria, tracking patient and transmission of this multi-drug resistant bacteria, and reports that information to the operational team that track multi-drug resistant in the hospital. So in this case, the collective action can help to fight antimicrobial resistance again. For me, it's what I think, but perhaps Didier and Philippe have some additional answer.
No, I think it's
for this difficult question.
No, this is it's true that this is a difficult question, and this
yeah.
is also.
So the next questions are about the novel approaches and alternatives to antibiotics for fighting AMR. So the question 8 is, what are the most effective alternative treatments that are currently available in clinics for treating AMR?
Yeah, it's also a question for treating patients. So there are very few possibilities now, and the first possibility I answer is to use old antibiotics such as colistin, temocillin, glycoside antibiotic, and in that case, in the lab, the microbiology must be able to test this old antibiotic. To test them, it's often necessary to determine the exact MIC of the bacteria because we don't have enough new guideline for this oral antibiotic. And in that case, the microbiologist must explain to the clinician, yes, I give you the MIC. This is not the MIC of the bacteria you have usually. You don't have guideline. And we propose to give you the MIC, and you can use this antibiotic in that case or not. So it's a discussion of the clinician and the microbiologist. The second possibility is to use a novel antibiotic. You have some of them just marketed, such as the cefiderocol, and also novel association using third generation cephalosporin plus an inhibitor of beta-lactamases, or the association of carbapenem plus an inhibitor of beta-lactamases. So again, in that case, the clinician must know if the antibiotic is able is able to treat the patient. So the microbiologist must be able to test them using an e-test to determine the exact MIC, or to perform the combination of e-test if you don't have the possibility to have a commercialized test. And again, it can also calculate the synergy of several combination of antibiotic. So, and last, some possibility could be also to use antibiotic in topic. For example, if you have an infection, bone infection, you can use some topic, and in that case, you can use again if the bacteria is resistant to the antibiotic because the concentration in topic is higher and can be able to kill the bacteria. The phage also could be an option in topic, and at last you can use also phage, but it's very complex to treat patients if you use it because when you use some phage, it's necessary to have a combination of the bacteria and this is phage, and you must be able to test a lot of combination, and this strategy is often used as last resort for treating patient. So it's I have not new alternative treatment. Didier and Philippe.
No, I think the next question will complement this one.
Yeah.
Nice.
The next question is quite linked, and it's what are the recent advances in antibiotic therapy, and if there are any new molecules that are soon to be available in the clinics or under development?
So there are, in fact, the WHO published a list of priority organisms for novel antibiotics or novel treatment. And these are mainly the gram-negative bacteria that are resistant to carbapenems or to different third-generation cephalosporin, and also Pseudomonas and Acinetobacter. And there is one issue for these bacteria is to enter the bacteria. So you might have very good antibiotics, very efficient, but if they will not enter into the bacteria, they will not be efficient. So there are quite a lot of work in the academic field to try to circumvent these difficulties, to try to make the antibiotics, for example, entering the bacteria, like with a fusion with something like which helps the antibiotics to come into the periplasm, or to add some adjuvants that will somehow potentiate the antibiotics. So there is research in this direction to improve the antibiotics that already exist. And I should say that in the academic field, there is really very, very diverse approach to address this question. This could be, for example, to try to address not only the survival of the bacteria, but its virulence, and to tackle the interaction between the bacteria and its host, the human host in this case, and this to try to eliminate the bacteria by this way. There is also the use of not very conventional antibiotics like monoclonal antibodies. And there is also one important way is the development of vaccines against pathogenic bacteria. So there are many domains of research in the case of mostly academics, and there are some startup or companies that are also in this field. In the case of larger companies, they are more classical, and this is mostly novel combination of beta-lactamase and beta-lactams that are more efficient or less susceptible to resistant mechanisms. But at the end, again, these novel treatments that are just derivative of existing treatment, the bacteria will rapidly become resistant to this treatment. So I think that the message is that there is in the academic field research in many directions. Most of them will not give interesting results, but we hope that some of them will provide some really innovative way to treat bacterial infection. And I should add, this is not my field, but in the case of Mycobacterium tuberculosis, that is also priority. There are some novel molecules that have been developed that are, for example, affecting the metabolism of the bacteria. So this is also a very active field of research, and that is, in this case, quite well supported in terms of budget.
So now we will move on to the questions that were asked during the live session. The first one is, what are the current research challenges in the fight against antibiotic resistance? And the specific question is, are there any data on the transmission of resistant germs among migrants?
So, Beatrice, do you have some information on the migrants and
It's difficult. The transmission is the transmission of bacteria, not the gene, especially. And we know that we have a lot of multi-drug resistance coming from Asia. For example, for gonococci, we have a lot of we have this kind of bacteria that can be able to be imported in, for example, for gonorrhea, we have some sexual tourism, and we catch some, the tourists catch some gonococci multi-drug resistance, for example. It's not migrant, it's it's not the, I don't know exactly if you have an answer to this question, perhaps for Mycobacteria, Philippe, the transmission of multi-drug resistance.
From migrants, if I can say something from migrants, I'm not sure that there are extensive data, but it has been clearly proven that people coming from Southeast Asia, for instance, are in many cases coming back carrying multi-resistant bacteria, or India. So that has been documented, and I guess in hospital there is it's taken into account before making any kind of intervention on people coming back from or arriving directly or indirectly from country where the level of resistance is extremely high, like India, China, Thailand, and all the Southeast Asia.
But it's not specific for migrant.
No, it's not specific for migrant. No. This is what I meant. Maybe I wasn't clear. But it's not specific for migrant, but there are data on the fact that people coming from a country where the resistance is very high are always carrying multi-resistant bacteria. It's documented.
Yeah, if I just regarding the first part of the question on the challenges, I think that the point that, of course, in for example, just knowing what is the level of resistance, what is the level, for example, the transmission, dissemination. So this is well studied in developed countries, in rich countries, but the knowledge of what's going on in low and medium countries is much more difficult to get. So there is less research, and it's much more complicated to do this kind of research. And so maybe one challenge is to really to improve this surveillance and the tracking of antimicrobial resistance at the worldwide level. And if, for example, in low-income countries, this will be mostly done in large cities and not in the countryside, for example. So there is a lot of gaps in our knowledge on the dissemination of antibiotic resistance. And regarding, for example, this question, as the two others have answered, we know very little on transmission. And of course, there are migrants in Europe, but when we consider what's going on in Syria and other countries, in Turkey, it's massive migration, and there is almost no study on what could be the effect in terms of the dissemination of antimicrobial resistance.
Okay, so the next question is about the duration of the treatments, and what are the antibiotics that we should take longer or less than 1 week?
Okay. Usually you use a long treatment for burn infection. If you have a burn infection, you can treat the patient last at least 3 months. If you have some protesis affection, 3 months. And also for tuberculosis, we have 6 months treatment. But when we have usually there are not this kind of infection, if you have a short an infection that need at least one week, it's usually the current treatment. We have some guideline to use 2 weeks for treatment of prostatitis. But all of clinicians now make randomized clinical trial to know if we can treat shorter. So it's not questions very clear. It depends of the disease, but at least it's usually 5 days a week.
Yeah, so I think it's, if I may compliment on this, is I think it's a difficult. In fact, there is a way to the dosage. So if it's a higher dose or lower dose, longer treatment, and these are these, as Beatrice said, it's the trial to try to find what would be the best treatment given the symptoms. It's a difficult question, and there is quite a lot of research on this to try to optimize the treatment, first to treat the infection on one hand, and also to limit the risk of selection of resistant bacteria. So there is these two aspects that are discussed, and it's really it's active research really to define the best treatment in terms of duration and in terms of dose.
It depends also of the patient, if you have an immunocompromised patient or not.
Yeah, if he has some other illness, and
yeah,
if he has
yeah, thanks. So the next question was a bit long. So it was about the scenario, potential scenario on of a multi-resistant organism in low and middle-income country hospitals, and what could be done in such a context to improve the way to handle them and handle the epidemics of those.
So this is feared that there is this hyperendemicity of multi-drug resistant bacteria that are very difficult to treat, and with antibiotics that are currently available and that are affordable in low and medium income countries. And that's the reason why I think that what I pointed, that there is a deficit in surveillance, and then if you are able to detect early the emergence of such really at-risk clone, possibly you can do something to make surveillance, and maybe to have some kind of action more worldwide, like what has been done in the case of COVID, where even the rich country realize that what's going on in low and medium country can be a risk for them also. So there is this, I think that what is really important is to have a good surveillance, and to also to propose some actions that could be feasible in these hospitals. Of course, if you will say you can do just what we are doing in rich countries, this will not be possible. So you have to find a smart way that are affordable for this country to limit the dissemination of such clone. And again, this is really really a very interesting field of research and very important.
Okay, so the next question was about if there is a possibility for assisted prescription. So maybe it's thinking about artificial intelligence assisted predictions, and I don't know, but with for the clinicians in case of emergence of resistance.
We know some antibiotics cannot be used in monotherapy. For example, with ampicillin, with quinolone, we have risk on emergence very quick. So it depends on the drug at the beginning. The alarm. We have some in my hospital. We have a lot of guideline for young medical doctor to give advice concerning the ideal posology, duration, and education. So this kind of it's a kind of alarm, but it's an education, especially education of the clinician to have a good prescription concerning the drug, concerning the duration. We have when we work together in the hospital, it's not and we have a mobile team for prescription of antibiotic. It's better than an alarm, and give also some combination using a discussion with the microbiologist and the clinician. It's also a good way to decrease the risk of emergence of resistance, to give also the good test in the lab, to give quick results also. It's not, it's a combination of all of that for me.
I think maybe one aspect is also the diagnostic, because many antibiotics are given, and this is quite logical, without any diagnostic on the susceptibility or the resistance of the bacteria. So this is kind of probabilistic treatment that we will select the best possible treatment, not knowing if the bacteria is susceptible or resistant to this bacteria. So this will depend on the context, for example, in the country. So this is one aspect. And of course, there is one way to improve this is to be able to do more diagnostic. So, for example, in Europe, in the hospitals, there is a systematic diagnostic on antibiotic susceptibility of the bacteria, but this is not done systematically. And for example, in some countries where the patient will have to pay for this, it will maybe say, I prefer to have the probabilistic treatment first, and then if it's failed, then I will have the diagnostic for susceptibility. So there is this issue to have really to reduce the cost of the diagnostic for susceptibility or resistance to the major antibiotics.
I completely agree. I add also the load in bacteria. If you have a load charge, very good, a lot of bacteria in a site, in one site, it can be difficult to treat the patient, and the risk of emergence can be easier.
The next question was more on recent discoveries about new viruses, I guess, that were discovered in the microbiota. So are you aware of those recent discoveries, and could you comment on those?
The virus and the bacteria from the microbiota, I mean, that's it's not specific of the fact that it's in the microbiota. Most of bacteria, of resistant bacteria, arrive already resistant. So I don't know. I'm not sure I understand really the question. Maybe Philippe understand it.
I think that this the bacterial virus will not really impact much. So only one risk with the viruses is that they can contribute to the transmission of antibiotic resistant genes between bacteria, but this will be just between bacteria from the same species, because viruses are very rarely crossing the species barrier. So for example, an E. coli virus can contribute to the transmission of antibiotic resistant genes to another E. coli, but there are many other mechanisms of transmission. So
much more powerful than the transmission.
So I would say that this is not a major risk for the development of bacterial resistance.
So the next questions are about antimicrobial peptides. So are there any promising combinations of those antimicrobial peptides that can be combined with other antimicrobials? And what are the limitations of the use of those antimicrobial techniques in clinical implementation?
Just one advantage of the antimicrobial peptides that they are not really considered as antibiotics. So there is it's easier to use them. For example, there is the Nisin, for example, is a kind of antimicrobial molecules.
They can be used as food additive.
Can be used as food additive, and so this means that there is more freedom to use them. One difficulty is that they can be degraded, so the stability of this antimicrobial peptide is limited. So and there is always one problem is to avoid to facilitate their entry into the bacteria. Sometimes the entry is limited, and they have one advantage also is sometimes they have a restricted host specificity. So this means that they will be the market will be more limited, but they will be they will have less ecological effect on the microbiome. So there is quite a lot of research on antimicrobial peptides, but for the moment there is no novel product that are on the market, and mostly as food additive, as Didier said.
Thanks for your answer. The next question is about CRISPR. Let me paste it. CRISPR treatments for antimicrobial resistance. Are there anything done in France or also maybe elsewhere?
Maybe I can answer. Yes, there are several demonstration of the effectivity of this kind of approach. There is even a company built on that principle, but who has extended its activity to other topics. So it's promising. The problem is that it's as of today, it's not allowed to use this kind of biotechnological tool for treatment. There are also other alternatives using other systems to kill specifically bacteria, but so far they are GMOs, and they are not yet. They have not even been allowed to use in compassion assay. No, it's the correct. Yeah. So yes, there are, but so far it is not allowed to go in human and to make assays of these approaches. But they have the advantage to be highly specific. And there is one of the last question is about the problems of dysbiosis caused by the antibacterial treatment or antimicrobial treatment, and this kind of very narrow targeted approach are clearly interesting to prevent this kind of side effect of antibiotic treatment and the dysbiosis and the imbalance of the microbiota. It's one of the benefit of this kind of approach. There are narrow spectrum antibiotics, but this is also an issue that can be handled with this new kind of therapy.
So maybe I can step out of my community manager role, and since I'm working in a lab that uses CRISPR, so my PI is also working on CRISPR to treat antimicrobial resistance bacteria. And also one advantage of CRISPR is that it not necessarily kills the bacteria. It can, for example, silence or disrupt only the resistance gene, and it can be combined with antibiotics. So it can be also one way to avoid resistance to CRISPR because you don't kill the bacteria. That's also something we could add to the interesting aspects of CRISPR, but also there are all those regulations problems that come with it. Okay, so now going back to my community manager role, and the next question that we have, and I think will be maybe the last question, because we are running a bit out of time. But then all the questions that were not answered during the live session, we will put them on the forum, and we could answer them afterwards. So the last question will be, could you please talk about your opinions about the role of natural transformation in the transmission of, I guess it's antimicrobial resistant gene, I guess, ARG.
I can answer perhaps if I can, if we think about Neisseria, because Neisseria, the commensal Neisseria and Neisseria gonorrhoeae can exchange the gene with natural transformation, and this transmission can be able to create multi-drug resistance in gonococci, because in contact with Neisseria commensal, and when we use some antibiotic like cefixime, we have proof that we can exchange a specific gene responsible of resistant to third generation cephalosporin with a mechanism of natural transformation. So it can be also non-suspected role for transformation for antimicrobial resistance. We know that some bacteria can be able to catch multi-drug resistant like this. Some Neisseria, Streptococcus pneumoniae can be able to use this natural transformation, but it's not usual for gram-negative bacteria from Pseudomonas.
Possibly in Acinetobacter.
Yeah.
Capture.
Sorry, I lost Acinetobacter. Thank you.
Okay, thank you very much for your answer, and thank you everyone for answering all the questions today. So with this, I think we are just on time for this live session, and we'll end here for today. Clémentine, if you want to...
Well, thank you everyone. Thank you for listening, and thank you to our directors. It was a very good live session. Sorry, there were a lot of questions, so we were not able to answer all of them. Some of them were a bit redundant with other questions, so we tried to select the one that were the most interesting to us, but we will come back in the forum for some remaining questions. And don't forget about the exam. So thank you.
Thank you, everyone.
Thank you.
Thank you and bye.
Bye.
Thank you and bye.